All right, well, thank you very much for this very gracious invitation. It really, really is a pleasure to have an opportunity to share with you some of the work that we've been doing, trying to better understand psychological factors that might be impacting on pain. And it's also really an exciting opportunity to be presenting with Claudine and Bonnie. This is going to be, for me, my first multi-stakeholder presentation, where I'll be representing the academic, and Claudine will be representing the consumer or client, and Bonnie, the clinician. So we thought the way we'd begin is I would give a brief presentation on what it is that we know about psychological factors impacting on pain. And then I'm going to be turning the microphone over to Claudine, who is going to talk about some of her experiences in navigating our health/mental health care system as a person with a persistent pain problem. And then finally, Bonnie will share with us some of her clinical experiences in targeting psychological factors that are impacting on her client's pain experience. So I'm going to be sharing my screen. I'm hoping that this works.
Looks good. We just have to get to the presentation. We see Zoom right now, Dr. Sullivan. That looks good. Excellent.
Are we good here? All right. So the purpose, there's many psychological factors that can influence pain experience. I'm going to be focusing today on catastrophic thinking, which is the area that I have focused most of my research on for the past several decades. So in terms of disclosures, none of the presenters has financial interest related to the material that will be discussed in this presentation. So back in 1649, René Descartes put forward the first comprehensive model of pain transmission in the human being. And with this illustration, he described that as the person's foot would touch the fire, that the fire would open up pores in the skin, allowing spirits to travel up tubes in the body until those spirits reached the brain and the person would experience the sensation of pain. Now, 400 years later, our basic conceptualization of pain transmission hasn't changed all that much, in that we've done away with terms such as tubes and spirits, and we've replaced them with words such as sodium channels and neurotransmitters. But we still think of pain as something that occurs when an event compromises the integrity of the body and triggers an electrochemical signal that's going to be propagated along different pathways until the signal reaches the brain, and then the person experiences the sensation of pain. Now, you'll recall that Descartes was a dualist in his orientation to the world, where he believed that the forces that govern the operation of the body were distinct from the forces that govern the operation of the mind. And for Descartes, pain was strictly a phenomena of the body. And that idea has stayed with us through the centuries as well, in spite of numerous examples in the world around us of individuals participating either in cultural or religious ceremonies where there is significant assault inflicted on the body, often through their own hand, and the individual appears to show no signs of suffering or distress. And these kinds of observations challenge our strictly medical models of what pain is all about. So Henry Beecher was the first to seriously start drawing attention to the possible role of psychological factors in pain. And he was an army surgeon during the Second World War. And when in Italy, he observed that individuals or soldiers would request significantly fewer analgesics for their injuries than civilians, even though often the soldiers had more severe injuries. And Beecher suggested that for many soldiers is that their injury represented their ticket to safety, in that they wouldn't be returning to combat. And here he proposed that this positive reinterpretation of their pain experience led to a lessening of the severity of their pain. And Beecher's ideas would be met with significant resistance, both from the clinical and from the research communities. They just were not ready to start acknowledging the possibility that psychological factors may be an important component of what pain is all about. But Beecher's ideas would live on and eventually become the foundation of what we now refer to as cognitive behavioral models of pain. And hundreds of studies have now been published showing conclusively that psychological factors are an important component of what the pain experience is all about. And the most convincing have probably been imaging studies showing that areas of the brain that subserve psychological functions such as cognition and emotion are also activated during the experience of pain. So pain catastrophizing is the psychological factor that I have focused most of my research attention on. And here what we're talking about is a way of thinking about pain that will actually make the pain worse. In the literature, pain catastrophizing is defined as an exaggerated mental set brought to bear during actual or anticipated pain comprising elements of rumination, magnification, and helplessness. And pain catastrophizing has emerged as the most powerful psychological predictor of adverse health and mental health outcomes that are associated with pain. The most consistent finding in both experimental and in clinical research being that high levels of catastrophic thinking are associated with the experience of more intense pain. In numerous studies, we would invite healthy young adults to the laboratory, and once in the laboratory, we would expose them to a painful stimulus. And in this study, the painful stimulus was immersion in very cold water. And when individuals with low catastrophizing scores immersed their arm in very cold water and rated their pain, they indicated that their pain sensation was at about 4 on 10 at the beginning of 1 minute and went up to about a 6 on 10 at the end of a minute. The individuals with high catastrophic thinking scores said that their initial pain rating was a 6 on 10, which rose to a 9 on 10 at the end of 1 minute. So exposed to exactly the same pain stimulus is that individuals with high levels of catastrophizing are experiencing pain at approximately 60% greater intensity. We also conducted studies where, again, we would invite healthy young adults to the lab and expose them to a strenuous exercise protocol that was designed to induce soreness in the upper arms and shoulders. And then we'd have them come back a day after the protocol and indicate on a body drawing where they experienced pain. And individuals with low catastrophizing scores reported pain in areas of the body that we expected, basically in the upper arms or the shoulders, the areas of the body that were targeted by the procedure. For high catastrophizers, however, we saw a spreading of pain beyond the targeted muscles, suggesting that catastrophizing may be a risk factor for the spreading of pain following an initial injury. In numerous studies, we also found that individuals with high levels of catastrophic thinking perceived tasks as more demanding, physical tasks as more demanding. So there was greater effort that seemed to be expended, or perception that they had to expend more effort to accomplish physical tasks. There's also been a number of studies that have examined what happens in the brain in high and low catastrophizers when exposed to a painful stimulus. And these are results from a study that was conducted by Dave Simonowitz and Karen Davis at the University of Toronto. And what they found was that following a painful stimulation is that the higher the catastrophizing score of an individual, the greater the activation in the areas of the brain that are responsible for facilitatory pain processing, as if for high catastrophizers, the volume on the pain signal was being turned up. And there's also parts of the brain that are responsible for dampening or controlling the pain experience. And for high catastrophizers, these areas of the brain are less likely to be activated. There's also some really interesting recent data suggesting that at least for some catastrophizers, for some individuals with high levels of catastrophizing, is that this is a genetically inherited characteristic. So that research shows that the correlation between catastrophizing scores in monozygotic twins is substantially higher than it is for dizygotic twins. There's also been a number of investigations showing that catastrophizing interferes with treatment response. And this is probably the most troubling side of being an individual who is experiencing high levels of catastrophic thinking, because not only does the individual experience more intense pain, is that the treatments that are available or have been developed to reduce pain are going to be less effective for these individuals. So research has shown that high levels of catastrophizing are associated with poor response to analgesics, to facet joint injections, to radiofrequency neurotomy, physical therapy, and even multidisciplinary rehabilitation. And the following is just a characterization of an individual who is experiencing high levels of catastrophic thinking.
I felt pain shoot right up my spine. So now I have pain in my shoulder, in my neck, in my back, and the bottom of my spine. It all hurts. And on top of that, the box fell on my knee, and that hurts too now.
All right, so what we see here is an individual with an overly alarmist orientation to her pain symptoms, reflecting in the experience of significant or intense pain, the spreading of pain beyond an injury site, and also significant emotional distress. So from a clinical perspective, our high catastrophizing client is going to be one who's going to be reporting more intense pain. It's going to experience more widespread pain. It's going to show evidence of sensitivity to movement-evoked pain. It's going to perceive physical tasks as more effortful. And it's going to show poor response to treatments designed to reduce pain. And so when a psychological factor is impacting to this degree on an individual's not only pain experience, but also their potential for recovery, it makes sense to be thinking about how can we assist individuals who are experiencing these high levels of catastrophic thinking? How can we make this a target of treatment? And that is what we're going to be focusing on today. All right, so I'm going to stop the share screen now, and I'm going to pass the microphone to Claudine.
Hello, thank you for that. That's great. You know, I was sitting there as a person who's lived with chronic pain for most of my life, thinking about what you were saying. And I'm now in a place where I can understand that and appreciate it clinically, as well as just, you know, as a layperson, what that means. But at the time, hearing those words, there's no way that that would have gone in and stayed in. It would have had a very visceral negative reaction to the word catastrophizing. I don't think I could have handled the concept that this is in my brain and I'm choosing a way to make my pain worse and or more intense is probably a better way of saying it. And so really having to take some time to think about that. Pain doesn't go away. So it's hard to find elasticity in your brain to think about it. But really being able to delineate between what is my frustration or my emotional pain and what is my physical pain is something that took me many years to discern. And I'm grateful that I've been able to, because I'm able to solve for either problem much faster in a much more effective way than I ever could have then. And so the concept of catastrophizing and the concept of, you know, it hurts everywhere, I'm very familiar with. It does hurt everywhere when you're upset, when you're frustrated, when things aren't going your way, when you're, you know, you can't stand any longer, but you're fourth in line at the grocery store. And there is, you know, a holdup over someone spilt something, someone's delayed in paying something. The pain levels go through the roof for me. And I notice that, and I have to listen to my body and say, okay, what's really bothering me? I'm being impatient. You know, yes, I'm feeling pain. I can take deep breaths. I can move around. I can, you know, there are options, right, for me. And I have to take it in that moment and think about it. But it's a big thing. It's a real thing. So for clinicians out there, when you're seeing, you know, patients coming in that have, you know, a chronic or a long-term pain situation like I do, being able to appreciate the words you use and how you use them will be the difference between us being open and wanting to hear about how we can help ourselves and leverage your skill set, but also just being able to delineate that there are other options out there besides whatever it is that we've been using to date to cope. Fair point, Dr. Sullivan?
Yes, very fair
Okay.
point. Yeah. So one of the things that we wanted to do was to demonstrate how one would introduce the idea that certain ways of thinking can impact negatively on one's both pain experience and recovery potential. And so as Claudine mentioned, one of the unfortunate aspects of psychology or mental health in general is that the words that we use to describe what people are experiencing are not necessarily words that people like being the recipient of, and it's and in the area of pain, catastrophizing is one of the words that a lot of clients have said, I just, I'm not crazy about the idea of being considered to be a catastrophizer. And I mean, I'll admit that probably in the area of pain is that we haven't brought the level of sensitivity required in order to have these discussions with clients. So for example, as a mental health practitioner, it's like as the previous speaker was talking about different labels that we have, is that most of the labels that we have in mental health are likely to be experienced as pejorative by many of our clients. But the idea is that you just don't use them. Just because they're part of your professional nomenclature doesn't mean that they have to be part of the conversation with the client. And so it's not that there's something wrong with the word catastrophic thinking, but it does not necessarily have to be part of the conversation with the client. And so in some of our work, in some of our clinical work in trying to target catastrophic thinking, we've chosen to use a terminology that is going to be less likely to invite a defensive reaction for a client, and also a terminology that's closer to what it is that we actually know about the phenomena. So one of the things that we know about catastrophic thinking is that it's a psychological factor that is going to be contributing to delayed recovery. It's going to be contributing to chronicity. So that's what we call it in a lot of our work. We refer to these as chronicity thoughts. And one of the techniques that we've developed, what we do is that we've had the client fill out a measure of catastrophic thinking. And what we do is that after the client has filled it out, and this is a technique we'd only be using for someone who obtained a high score on the measure, is that we indicate to the client that, so if I was speaking to Claudine, I say, one of the things that we've learned in research, Claudine, is that recovery is not just about taking the right medication or being involved in the right type of activity. It's also about a way of thinking, and that there's certain ways of thinking that can impact negatively on our recovery, and other ways of thinking that can promote our recovery. I can say, this is a form that contains some of the items from a measure that you completed last week. Now, Claudine, do you have that form with you? The Chronicity Thoughts for? All right, good. See, if we were in the same space, I would be handing this form over to Claudine. But given that we're about 2,500 kilometers apart, we've done it electronically. So what I can say to Claudine, I say, so these are items from one of the measures that you completed the last time we met. And the first item on the measure is this, what we refer to as a chronicity thought. And these are different thoughts that you indicated that you experience often. Now, what I would like to do here is that I'm going to read the chronicity thought. And what I would like you to do is read the recovery thought that follows it. All right?
Okay, I'm up for it. Are you going to share your screen?
Am I going to share my screen? Let's see if we can do that. And I believe it's this one. All right.
Perfect.
Do you see that?
Yes, thank you.
All right, so I'll read the chronicity thought. I become afraid that my condition will get worse.
I am confident that my condition will improve. I'm just telling you that bites a little to say that, but I'm going with you. I'm on the train with you.
Okay. I feel I can't stand it anymore.
I will deal with this the same way I have dealt with other major challenges in my life.
I can't seem to keep my pain out of my mind.
If I stay busy, I can turn my attention away from my condition symptoms.
There is nothing I can do to reduce the intensity of my symptoms.
I am confident that I will learn ways of effectively managing the symptoms of condition.
I wonder whether something serious may happen.
I'm confident that nothing serious will happen.
My symptoms are awful, and I feel that they overwhelm me.
My symptoms are challenging, but I know that I will learn to deal with them.
I worry all the time about whether my symptoms will end.
There are more important things to do with my time than worry about whether my symptoms will end.
All right, so at this point, so this is the first session that I'm introducing this technique, and all I want to do here really is introduce Claudine to the idea that there's different ways of thinking about one's pain, and that some of these will promote chronicity and others will promote recovery. And so what I'm going to tell her now is say, what I would like you to do, Claudine, is for the coming week, I want you to keep this form with you. And every time you experience one of these chronicity thoughts, I want you to repeat the recovery thought below it silently to yourself 3 times.
Okay.
Can you do that?
I can try. I can absolutely try. That's not going to cause me pain. So I'm in.
All right. So Claudine, as a client, if you were experiencing this for the first time, what would be your reaction to this conversation?
That is crazy.
Okay.
Totally honest, right? You're walking in and, well, in my case, I wasn't walking very well. I'm coming in, I'm in pain, just sitting down on the couch or the chair or whatever is a problem. And I'm like, you want me to say things in my head. That's what's going to fix this. Oh, okay.
Right. Okay.
It's that kind of a thought process.
So I know that just giving this form to Claudine is not going to do the trick. But before we take the second step, I at least have to introduce her to the idea that there's different ways of thinking about pain, and some will help us and some will hinder. And I also want her to get used to having these kinds of thoughts in consciousness. So I know that the chronicity thoughts are things that she's experiencing often, because that's what she indicated on the form that I asked her to complete. So now what I'm trying to do is, at least in terms of awareness, have that replaced by a recovery thought. But I also know so that the recovery thoughts are essentially thoughts that are all phrased in terms of a more positive orientation towards the future of one's condition. And one of the things that we know is that positive expectancies are one of the really, really important predictors of successful recovery. Might be the wrong way to say it, but let's say of significant progress in adaptation to a persistent pain condition. So I want to make sure that these thoughts are inside Claudine's head. So that's what I do in my first session. Now Claudine says that this is going to be completely off the wall, the way she'd experience it, but I wouldn't be doing this in the first session that I meet her. This is just the first session of me introducing this. So I would have tried to warm her up to the idea that psychological factors are important elements of our pain experience before introducing this technique. All right. Now, one of the things about whether a certain way of thinking is going to be impacting in a meaningful way on our experience is that we have to believe the thought. And so the next time I meet Claudine, what I want to do is have a discussion about how much she believes in these thoughts and what are some of the barriers to believing in these thoughts. And just for the sake of efficiency, I'm going to be showing you a video about what that might look like, and then we can have a discussion about it after. All right. So let me see if I can fire that up. share screen again. Yeah. And all right, so just for illustration, these are two of the items that are on the form. And again, what I'm hoping that Claudine is going to be doing in the week before I meet her again is that she'll be aware of when she experiences the chronicity thought, she'll pull the form out and then repeat the recovery thought 3 times. All right. So this is how a second session might unfold with the client. I'd like to spend a few minutes now talking more about chronicity and recovery thoughts. Last week, I asked you to repeat a recovery thought 3 times to yourself each time you experienced a chronicity thought. How'd that go?
It went okay. The thing that made it difficult is that you're not always aware of, a chronicity thought that you have. But when I was aware of thinking things like, oh my God, this is not going to get any better, or maybe something was missed on the scan, I would repeat the recovery thoughts. I wasn't counting, but there seemed to be fewer chronicity thoughts popping into my head as the week went on.
That's great. That's what's supposed to happen.
And you said you were going to quiz me?
Well, I really wasn't intending to quiz you. I just wanted to underline the importance of the exercise.
Well, I remembered them all. I am confident that my condition will improve. I will deal with my challenges one day at a time. If I stay busy, I can turn my attention away from my pain. I am confident that I'll learn new ways of effectively managing my pain. I am confident that nothing serious will happen. My pain is challenging, but I know I'll learn to deal with it. There are more important things to do with my time than worry about whether my pain will end. I think that's all of them.
I'm impressed.
Well, if you had to repeat them as often as I did, you'd eventually know them by heart as well.
Well, here's another copy of the Chronicity Thoughts form. It's the same form that you took home last week. We're going to do something a bit different today. I'm going to read a few of the recovery thoughts, and for each thought that I read, I'd like you to tell me, on a scale from 0 to 10, how much you believe the thought. 0 being not at all, and 10 being completely. I'm confident that my condition will improve. To what degree do you believe that?
Believe that my condition will improve?
Yes, on a scale from 0 to 10.
Maybe 6 on 10?
I will deal with my challenges one day at a time. How much do you believe that thought on a 0 to 10 scale?
7 on 10?
So for the thought, I am confident my condition will improve, you rated your level of belief as a 6 on 10. How come it's not higher? How come it's not a 10?
I guess I can believe somewhat that I will improve, but it's hard to have a lot of faith in that. I guess it's been over a year and I haven't noticed any improvement in the last few months.
A year ago, the pain was worse?
A lot worse.
So there's been some improvement.
I mean, there's been a lot of improvement, but the pain is still quite unbearable some days. And I haven't noticed any improvement in the past few months.
What would it take to get your belief rating up to a 7?
I'd have to see a reduction in my pain.
How would you rate the intensity of your pain right now?
Probably a 6 or a 7 on 10.
So if your pain came down to a 5 on 10, your belief rating would go up to a 7?
Maybe.
I'm rather certain that your pain will be reduced by at least that much during the course of the work that we do together.
How can you be certain of that?
In the research that's been conducted on this type of treatment, we usually see about a 30% reduction in pain.
If my pain is reduced by that much, then my belief rating would likely go up.
But I need you to believe that now. I need you to believe that it will go down.
Why?
Because believing is going to be part of what will reduce your pain. As you know, the mind plays an important role in how we experience a health condition. There's been so much research showing that believing that one will recover actually promotes recovery. So if you're hoping that your pain will decrease, you need to believe that it will decrease.
I don't know. It seems to me that I would need some kind of proof that my condition will improve.
Proof is good, but it's not necessary. The human mind works in a way that it is able to believe even in the absence of proof. As children, our parents led us to believe in fictitious beings like Santa Claus, the Easter Bunny, the Tooth Fairy. We really didn't demand proof. As adults, we might believe in certain spiritual figures, an afterlife, political ideals, or the true love awaits us in our future. And again, we're able to believe even without proof. So the part of your mind that makes it possible to believe in the absence of proof, that's the part of your mind that we need to have working for us, working to help your condition improve.
I can try, but I'm not the kind of person who believes in a whole lot of things.
But if believing might help in your recovery, it seems to me there's no harm in trying.
I guess I can try.
When we think of recovery from a painful injury, we typically think of complete relief of pain. But recovery is much more than that. Recovery is also about resuming our participation in the important activities of our lives. So in our work together, we're going to proceed with this broader perspective on recovery. We'll be aiming for some reduction in the intensity of your pain, but we'll also be aiming to have you be as full a participant as possible in the important activities of your life, despite the pain symptoms you might continue to experience.
I'm okay with that.
The second recovery thought we looked at was, I will deal with my challenges one day at a time. You rated your level of belief in this thought as a 7 on 10.
It would be about that, a 7 on 10.
I'm happy with that rating. A 7 out of 10 or greater is about where we want to be in our belief ratings. What would you say has been the most significant recent challenge that you feel you dealt with successfully?
My daughter deciding she wasn't going to go to university.
And how did you experience that challenge?
Well, not good at first. Understandably, I was disappointed. Throughout high school, she had talked about doing an education degree. She applied to a few universities and got accepted to almost all of them that she had applied to. And then she told me she wasn't going to go. She said she wanted some time off school, figure things out. We had a few arguments, and, well, I said a few things I shouldn't have said.
So how did you resolve this challenge?
Well, I talked to my husband and a few of my friends, and then I came to the realization that this was her life, and she had to be certain about the path she chose. So taking some time off might be the right thing for her right now. We had a few more talks, and in the end, I told her that I respected whatever decision she said she needed to make at this time.
So this was a challenge where you and your daughter were looking at the future through different eyes. You were experiencing a lot of worry about the potential negative consequences of her decision. And then you were able to pull back and see that she needed to make her own decisions about her future. It seems to me that you have the ability to take on some major challenges and come to a sound resolution. That ability will be an asset in meeting the challenges that your pain condition has brought to your life.
I hope so.
All right, so that's an idea of what it would look like addressing the client's level of belief in the different recovery thoughts. And what I would be thinking of doing is each session is targeting about 2 of these both chronicity thoughts and recovery thoughts. And you really can't do more than two in one sitting, because it's a lot of information to process. And you also want to be in a position where you can get the client also to capitalize on the strengths that the client has and how she's met previous life challenges. So anyway, at this point, what I would like to do is turn the microphone over to Bonnie, and who's going to share with us some of her experiences in using these techniques with some of her clients.
Okay, well, thanks, Mick. So part of the reason that we're talking about this specific tool is because it's actually very easy for healthcare practitioners from a wide variety of backgrounds to just take something that's so concrete and transparent, like to be able to talk about thoughts without having to be a psychologist is actually quite empowering. And so I've been to some training. I've been watching webinars and that sort of thing by Mick Sullivan for a few years. So this wasn't brand new, but when I first learned this tool, I thought, that's something different. Like I haven't tried this before. And so I decided to go with it. And I'm going to tell you a little bit about my experience, but by working in this little group with Mick and Claudine, I've also learned a few words to avoid and just more aware of how it might feel from the receiving end. And I think that's the real value of having Claudine here, helping us to understand how this all works. So what I did was I got a copy of that handout, Challenging Chronicity Thoughts, and I tried it out with a couple of my clients with long-term chronic pain, with also depression and PTSD. And I started off, at first I used the pain catastrophizing scale because I was more familiar with that, but then it doesn't quite align with the questions. So there's another scale called this Symptom Chronicity Scale, or SCS, and you can find that on the internet quite easily. So Symptom Chronicity Scale, and it'll ask for people to rate whether they have these thoughts never, sometimes, or often. And that score will be out of 14. And then when you use this, the Challenging Chronicity Thoughts handout, you're actually directly trying to intervene to try to make a change to the thoughts. And I'm just, sorry, I have some notes just so I keep on track. So I tried it with a couple of clients, and in particular, it really opened up a conversation about some thoughts that were normally kept very carefully hidden. And so I didn't necessarily realize some of the underlying thoughts that were happening. And I'm sure for Mick, this would be something he would be asking about right at the beginning. But I was really focused on function and getting back to activities and not necessarily appreciating some of the underlying thoughts that were getting in the way. And so I implemented it, and it was going pretty well with some, but there were some challenges. So there were, just like Claudine said, there were a few clients that told me they had difficulty believing the first recovery statement. So that was, I am confident that my condition will improve. And so I let them modify the words, so it was something that they could believe, even if they're just moving a little bit forward. And it usually reflected that they recognize that the things they do for themselves, for self-care, do make a difference. So maybe at least that their condition wouldn't get worse if they were to do those things. So that was an important one. And then I did have one client who claimed that he doesn't have thoughts like this. But that actually was just something I needed just to be curious about that and explore it. He kind of put up a barrier, and I thought, okay, well, I'll accept that. I'll just be curious, and we'll kind of work on this in a less direct way. So not 100% success. I'm going to tell you about a couple clients where I think it worked really well. So I had a client with back pain who was close to returning to work in an office job. And he was dealing with all that uncertainty that you would feel before a transition like that. So he posted the handout at his desk at home, so he would see it frequently. And when he would notice a thought, immediately his eyes would go to the handout. He found that just really, really helpful as a way of reinforcing. So it wasn't necessarily that he'd catch himself in the thought, but it was right there. So that kind of cued him to notice. And then another one, a lot of these I did virtually, I have to say too. So I emailed it to the person, and then we put it up on the screen just as we did here. And then a few weeks after we had done this, and I use it as an activity, actually. I like to have an activity in my sessions. And so then I met with a client and we went for a walk. And one of the things he was trying to do was get out for a walk. And he showed me the folded up piece of paper that he had printed out. And he explained to me that he takes that with him in his pocket every time he goes for a walk, because sometimes his knees start to hurt. And then he starts to have these very strong thoughts about self-blame, really, really like challenging thoughts. He'd pull out the paper and he would read it, maybe even think about the session we had, and it would stop those thoughts. So, I mean, that was just like amazing to me, because I was thinking, oh, that's great that he's out walking. And I was missing what was happening in his mind as he was out there. So that was a real powerful story for me anyway. And so did I take anyone to a 0 out of 14 on the symptom chronicity scale? I don't think so, but I moved them a little bit. And as Mick said, these are extremely challenging to change. So if I can do something that will kind of turn things in the right direction, I'm all for it. So I just really want to encourage people to not necessarily have to take on everything, but try something new that you learn at this conference. And maybe this will be the thing that a few of you will put into practice and give a try, because it's really quite doable. But also think carefully about what words you choose and trying to avoid don't say catastrophizing. Watch your words and it'll go over quite well. I'm gonna go back to the full group here.
Thank you, Bonnie, so much for your efforts in this. Speaking on behalf of patients or people with lived experience, we're all humans. I applaud your efforts on this. It matters. Like, it really matters. So thank you.
Thank you.
And one of the things that we've been trying to do over the past many years, it's to try to develop approaches to intervention that will target psychosocial risk factors for delayed recovery in a manner that's going to be accessible to a wide range of health professionals. We're in a situation where even though we understand that, yes, psychological factors play an important role in our experience and our recovery from painful conditions, is that we don't have enough psychologists to provide services for all those who are in need of those services. And so we've worked very closely with occupational therapists, physical therapists, kinesiologists, nurses, to look at how these kinds of techniques can be incorporated into the repertoire of services that they would typically be offering to a client. So anyway, at this point, I'm trying to be mindful of our time as well. And so am I thinking, should we be going towards an open discussion or questions at this point? Christelle?
Well, hello, everyone. I just want to acknowledge that this is a very creative way to learn, to hear about a concept and to see it displayed. So I want to thank you for stepping into that, leaning into it. I know there's a lot of work and effort into that. So just want to acknowledge that. Sure, we can definitely go into some questions. We can have some further conversation. It's about 3:25, so we're spot on. We have about 10, 15, 20 minutes for conversations if we'd like, or we can also give back time. So I've got one question. I'm sorry, I'm using my phone. We use different technologies, as you may know, to relay different questions. And I think it's thoughtful about building what is the purpose and how can we just work with each other to just start this process. And it comes really with, how do we build up hope to folks that might be scared or who lack hopefulness when it comes to working and stepping into this area of, having a chronic thought, so to speak. So it also builds on, does it matter if they say, I'm confident I'll improve, but they don't really feel that way. Could you share with us what you think?
So I'll just touch on the confidence thing from a research perspective, and then I'll let Claudine and Bonnie touch on it more from an experiential and from a clinical perspective. So one of the things we know about thoughts and how they impact both on behavior and experience is that you have to have a certain belief level in those thoughts. I mean, one of the reasons that catastrophic thoughts impact so negatively on experience is that people have a high level of belief in them. It's like those human beings experience their spontaneous thoughts with a high level of truth value. When a thought arrives in consciousness, you just assume it to be true. And that's, for catastrophic thoughts, one of the reasons why it has this negative impact. So if we're going to be trying to replace catastrophic thoughts with recovery thoughts, we first need to get the thought in the person's mind. And then what we need to do is work on the level of belief that the person has in it. And where we need to be is 7 or greater. So that once a person's belief level is at 7 or more, is that research suggests that at that point is that thought now maps on in a clinically meaningful way to outcomes. So that's where we want to be. And so in my interaction with the client, when the client has a rating below 7, I want to know why. Saying, what are the barriers to having a higher belief rating? And the client's responses might become part of the substance of what we're going to be working on. So I want to reduce the barriers to having a greater level of belief in them. So Claudine, what's a challenge in believing that things are going to get better or to be more positive?
I think it's, in all honesty, experience, right? And so as a patient, 20 years of this, and I'm walking in and someone's saying, do you think your condition can get better? I'm going to say, sure, if you can offer me some miracle, it's going to get better. But at the same point, right, this is where the concept of trust in your providers becomes very important, relating to, on a human level, from clinician to, patient, if you want to call us that, to being able to dialogue about that and ask questions. So I may not agree with that sentence, but I know logically that I can manage my condition. I know I can do that because I've been doing that. And so it's a little bit of taking that conversation, just like you were saying, Dr. Sullivan, it's one day at a time. You can't just throw up all over someone and expect them to be on the train with you, right? It's a process. And so for Bonnie to be starting these conversations with her patients is really important because it breeds that sense of dialogue and trust. And so when I walk in for physical therapy and they say, how are you doing today? I'm great. I'm fine. Can we get to the, what are we supposed to be doing today? Right. And it's, well, hold on. What's been a challenge for you this week? I've got this going on and this going on and nothing's going right. The world sucks. I can't handle it. It's like, okay, we need to take a step back. We can't jump into physical therapy right now. We need to understand some of those things. And then it's sort of a conversation about mobility, right? And so dialoguing with us that way is helpful. We have to be able to think of ourselves as solution providers too. And that is not an easy conversation to have necessarily. It certainly wasn't with me. You heard me say, I'll try. I can do a lot better than try, but I got to get there in my head. And I have to be able to understand how I can do that. So the more you have me repeat these things, even if I don't buy into them, the more I'm going to start having some elasticity in my brain to receive them and engage them and purport them out into my life. And it's not just pain that you use these comments for. It's for everything. It's for that moment when I'm in the grocery store and I'm frustrated. Or, my child, needs to go to the doctor's appointment, but he still hasn't gone to the bathroom first and we're already late. It's all of those things, right, that come up in your life. These thoughts are not just for pain, but they work really well across the board. And, you know, taking the concept of chronicity, and this isn't going to work for everyone. It certainly wouldn't have worked for me at first, but it works for me now, is changing that conversation to the power of positivity. And how can I put some positive thoughts in my head? Yeah, I'm dealing with some pain today, and I get to go see my child's graduation, right? It's connecting the dots between things. So I'll leave it there. I'll pass it to Bonnie to fill in some of her perspective on this. But this is something where we as people with lived experience really need to get engaged and have these honest conversations with our clinicians, regardless of their practice.
Okay, so what I wanted to comment on was the word confident is an issue with two of the statements. And the way I got around that was just simply getting my clients to revise it. I sent it to them as a Word document and I let them change any words that they felt they needed to. And then I negotiated a little bit, because if it didn't meet a little bit of pushing them into a bit of discomfort, maybe that wasn't enough. But I thought that by giving them that control, that was really important. And then, you can always try to advance more slowly if needed. And I did want to add, just it came to my mind as we were talking that I missed pointing out that the way the wording is, where it doesn't say pain, it says symptom/conditions. That was really, really helpful for me, because I was often focusing on pain management. And these were people who also had PTSD. And this totally worked for both. And it was great. It made me understand their experience a lot better.
I'm so impressed with that conversation, because as someone who has, lived through PTSD and support for it, words matter. I know I say this a lot, but they do. And the word pain takes your brain right to feeling pain. When you talk about symptoms or your situation, or, there's a million words you can use to talk about it, but it changes the conversation from, turning that light bulb onto pain versus being more open and fluid in the conversation, again, regardless of your clinician. And there's always a middle ground. There is always one. So if you don't like the words, change the words, find a different word, ask them for a word. It's the same conversation, it's just a different word, and it's okay.
Yeah, and as Bonnie and Claudine reflected, for individuals who have a chronic condition, it's going to be really difficult for them to believe, at least at the beginning, that their condition will recover, because they've got tons of evidence that it hasn't been. And
Yep.
As by the time you're considered to have a chronic condition, then by definition, every treatment that's been offered has failed. And you go through a whole bunch of failure experiences. It's going to be very difficult to be optimistic about the next one that's being proposed. And that's why it's also important to invite the client to adopt a broader conceptualization of what recovery is. That it's not just getting rid of the pain or getting rid of one's symptoms, but it's making sure that we're taking the steps to be as full and as meaningful a participant in our world. And because one of the things about pain is that not only does it feel horrible, but it pulls us away from our participation in the world that defines us. And we need to get the client to consider that, it's like, we're going to do what we can for the pain, but in spite of the pain, maybe there's some things we can bring back to your life, some of the things that were really, really important to you that pain has taken away, And so by inviting the client to be thinking more broadly about what recovery is all about, is that there's less of a focus on ensuring, or let's say on requiring, that the pain go down a certain amount before the person starts feeling more optimistic about their life.
The other thing I would add to this, because that's so true, right? We're onions, all of us. It's one layer at a time. But the whole concept of this catastrophizing scale, and you can see the look on my face, even having to say the word catastrophizing scale. Like, we need a new word for this. So if anyone wants to create one, I'm all ears. That being said, it's an incredibly eye-opening process as a person with lived experience to recognize that your thoughts are so intrinsic and built into your day. I didn't realize how negative, and that doesn't even necessarily describe it, but I didn't realize how ongoing it went throughout my day. So just doing this scale and then taking it home as homework, you're like, wow, I'm doing this all day long. And now you're recognizing it for yourself. And now you're your own advocate because of it. You're able to catch it, not always, because we're humans, but you're able to catch it and address it. And you know what? I don't have to think that way. That's a choice. How I choose to think about it is a choice.
And really building on that, I hear a lot of discussions among the three of you regarding seeking feedback. How is this working for you? And asking for permission to provide feedback on that, and actually taking the time just to provide awareness. You know, are we aware of our thoughts and where they go? And can we take the time to notice? I can see that, you know, it can be uncomfortable and what have you. And you express that so raw and honestly and authentically, Claudine. And I'm sure you're not alone in feeling that way. I guess building on that, you know, being able to have these types of supports to look at awareness. What do I do with this? How do I practice it? And how do I keep repeating it? And how do I move forward? Did you yourself, if I could ask you this, Claudine, experience something like this in your treatment? And if you did, how did it go? And if you were to do it now, like with the information you have, can you compare and contrast if you feel, you know, like?
Yeah, sure. So yes, I was given a pain catastrophizing scale to fill out. I had no idea what it was or what it was about or any, like, it was just, you know, fill it in. And after you do, you meet with, you know, your clinician and you realize the importance of it. And it's like, you know, I remember having this conversation of, is there a time in your day-to-day where you don't feel pain? And I had to sit there and think about that and go, you know what, when I'm with a customer, I'm doing some sort of lobbying, or I'm, you know, on, as it were, presenting or whatever, I don't feel pain. I am on a whole other level and my brain is focused on exactly that. And that means my brain is capable of turning off the pain. That was the most light bulb moment for me ever. So the comment on the scale of, you can stay busy and manage your pain. It's possible. I can't do it all day long. I don't have that kind of brain power, but there are moments and I can do that myself. And so the idea of it then was, this is just, do you want me to say what to myself all day long? And then living through it going, wow, I really do have a lot of negative thoughts, a lot of them. It's consistent throughout my day. I wake up feeling negative. I go to bed feeling negative. And the more I practice this, the more I'm finding some capacity in my brain to literally think about this differently and delineate pain from emotional pain, because they can manifest the same way, but they're not the same thing. And you need to, from my lens, address them differently. And so your pain is real. I have a lot of pain in my body on any given day, and I accept that, and it's okay, and I can manage it. Now I can take that thought. If someone says to me, Claudine, you know what can you do about that? I have 107 different things I can do about that, and it's okay. But this took years. It's a practice. And this came through my nutritionist, my massage therapist, my PT, my clinician, you know, my, like, everybody, my pharmacist, like, everyone was on board with this, of helping to challenge me through that process. So I'm very grateful for having such an amazing team.
And one of the things that Claudine mentioned that's really, really important is, you know, it's the tools that you're going to be using to manage your pain, they have to fit into your life. They have to fit into your day, so that we know that, it's like psychological strategies like distraction can be helpful in reducing pain intensity, or that things like relaxation can reduce pain intensity. But you just can't do those all the time. You can't be distracting yourself 24 hours a day, and you just can't find a place to lie down to do your relaxation exercises, like when you're on the bus. And so what you want to do is try the best you can to provide your client with a large repertoire of tools that the client can use in a manner that is going to be fit the moment that they need to use the strategy within.
That's so true. There are so many questions here, and I'm definitely going to give us at least 5 more minutes. So I'm going to keep the conversation going so we can invite a few more discussion points. I really liked how setting the stage, so preparing someone, the expectation, and I know there was a bit of conversation with Dr. Mate regarding expectation. And so we won't go there right now, but setting the stage as to the purpose behind things, that words matter, and regarding what we might be hoping to accomplish, and saying, what is the difference between, choosing a lower number that you did when you spoke that recovery thought, and if you believed it, and the numerical scaling. And so for all 3 of you, from research, academic, developing, creating, delivering it, Bonnie, and for your personal experience, Claudine, how can we continue along those lines of preparing each other for this, having open dialogues, and ensuring that this becomes a very valuable and meaningful interaction? And I'll start with you, Claudine.
Well, for those of you that know me, I live in a world of candor. I just need the brutal, honest truth. And if I'm coming in to see, my occupational therapist, I want to have that candid discussion about the value of the scale and where we're going with it and why it matters, because I'm a human being. I'm not just there to learn how to walk again. I need the full therapeutic support as a whole human, and my legs aren't going to move if my brain isn't in the right capacity to move them, right? And I need that power of positivity, and sometimes I just need to say, this has just been a bad day, and I don't know how to get out of this fog. I need some help here. And having that trust to be able to do it is important. But from my lens, it's just, I would like to think that everybody listening is understanding the value that they can bring to this conversation. You don't have to be Dr. Sullivan. You don't have to be Bonnie. You have to be yourself, and talk to your healthcare providers or talk to your patients, depending on what side of the table you're on, and really open up and share, because nothing happens when you don't share. Nothing better is going to come of it. And it's hard to share. It's hard to trust one more person that may not see what you're living through. Your pain is real. Regardless, it's real. And you can think about it differently. You have a choice. But I think it's important that everyone understand what they can bring to the table on this. And I know as a patient, it took me a while to figure that one out. So that's my 2 cents on it. Bonnie, what do you think about this?
Oh, well, yeah, I feel so very much in the middle, where I'll attend courses or workshops and that sort of thing, and I get all this great information given to me. But if I don't use it with some of the clients that I've been challenged with, then I'm not gonna learn that. So I really love the fact that I have some really complex clients, and also through the pain clinic that I work in Camrose in Alberta Health Services too. These are people who really need a lot of psychological intervention, and the resources are not there, as Mick has said. And so if I can do a few things and help them to open that up, and then they teach me as well. So it's just like I'm learning from Mick, and then I'm learning from Claudine, and it's just constantly trying to find ways to improve my practice. And if you don't just try something new, you're not going to know. That's all.
And I think there's been a much greater openness in recent years into thinking of a treatment situation not as a giver of services and a recipient of services, but rather as a collaborative effort to try to bring the client to a better place than they're in. And I think that through that, I think that change in the character of helping relationships, I think there's a lot of professionals that have also come to realize that you really do need the client's perspective on how they're experiencing the treatment moment, because it's like a lot of what we're taught is from studies where a standardized kind of approach was used for treatment. Well, standardized approaches are, they're great for most of the people most of the time, but they're not always going to work for all of the people all the time. And as Bonnie described, is that sometimes we have to adjust our tools to how a client is thinking about the situation, or how the client is receiving it. And we have to allow, I think, that type of flexibility in the work that we do with our clients.
I think that's well said. It's reflecting the space and the place that we meet our patients in, and continuing to build that trust and that really good therapeutic relationship. Again, I want to keep going, but I'm conscious of time. I do have a couple quick questions. Bonnie, some of the folks on chat were just having a bit of challenge finding that symptom scale. So I'm wondering if you could pass along to us later on, maybe the website or the link, and then we'll pop it into the chat box if we could encourage that. That would be great.
Do that.
Oh, wonderful. Thank you. And I'm also wondering, so many people are asking about the Chronicity handout that we're talking about. And if there's a possibility to be able to look at that or have access to that, I will take that offline with you, Dr. Sullivan. I don't know if that's available to folks, but they just were very excited about being able to work through that and see it more. And so I don't know if you have any comments on that with us right now.
I think probably what we'll do is, why don't we put that up as a download on one of our sites? And when that's up, you can orient people to the website and they can just go and download it.
That's wonderful.
Okay.
That'd be great. Thank you so much. And again, I want to thank all three of you for your hard work, making this personable and showing what this could look like, and how we can step into this with our folks that we're working with, and how someone might receive this, who maybe when they work with their healthcare team, there was vulnerability, there was some good humor, there was honesty. Great job, team. And thank you for contributing to the World Pain Summit this year. Really appreciate it.